Good evening to all the attendees and welcome to the ATS ALAT SBPT joint webinar, Global Perspective on COVID-19. I am Gustavo Zabert. I'm the president of ALAT, Latin American Thoracic Society, and also I'm associate professor of medicine in the Faculty of Medical Science at the Universidad of Comahue in Argentina. I am joined here as an invitation of my co-moderators and chairs of the International Health Committee, Dr. Samya Nasr and David Lewinsohn. Dr. Nasr is professor of pediatrics and director of the Cystic Fibrosis Medical Center at the University of Michigan. And Dr. Lewinsohn is a professor of pulmonary and critical care medicine at Oregon Health and Science University. My pleasure to introduce David to come to the webinar.
Thank you, Dr. Zabert. Well, I would like to thank the Latin American Thoracic Association, as well as the Brazilian Thoracic Society for their collaboration on this webinar, as well as our distinguished international panel of speakers providing their insights into the COVID-19 pandemic. The aim of the International Health Committee is hosting the Global Perspectives on COVID-19 webinar is to allow respiratory health professionals in different regions to share their experiences with COVID-19 to date, and to have an opportunity to ask questions to their colleagues in other regions. This webinar will include practitioners and professors from Argentina, Brazil, and the United States. And before I begin, we have a few brief notes and reminders. First, due to the large number of registrants, we have muted all of the participants' lines. Second, please feel free to send in questions in the questions box. We will be monitoring questions and will do our best to address them either during the webinar or a post-webinar Q&A that will be made available on the ATS COVID resources page. Third, at the end of the webinar, we hope that you will all complete a brief feedback evaluation for us to help with future planning. And finally, please note that a recording of this webinar will be made available to all registrants and posted on the ATS website. And with that, I would like to introduce our first speaker here to give his perspective from the United States. This is Professor Fernando Holguin, who serves as a professor of medicine in pulmonary sciences and critical care at the University of Colorado Hospital. Dr. Holguin.
Thank you, David. I appreciate it. Can you hear me okay?
Yeah. Yes.
Yeah. So thank you. Thanks for the to the ATS organizers and Christina Brass for inviting me to present in this important webinar. And I'll give you some perspectives about what's happening with the COVID epidemic in the United States, and also give you some of the areas that we consider to be of important clinical uncertainty that perhaps we can discuss further during the webinar. So in the United States, this graphic clearly sort of represents what's been happening. You can see the number of daily confirmed cases, the 5-day moving average, and how it has increased from March 15. See an exponential increase of cases till around the end of March into the beginning of April. And now we're seeing a plateau of the number of new cases, although the number of deaths continue to increase at a slightly higher rate. But clearly there's still, even though there's some plateauing of the curve, there's still quite a bit of burden of disease. And suffice to say that the States right now, there's about over 1 million cases, which corresponds to about 25% of the global burden of disease. And you can see how it's much higher caseload compared to some of the countries outlined here at the bottom of the graph. Now, however, due to the prevalence of many comorbidities, a lot of issues related to segregation, and many social and structural inequalities, many underrepresented minority groups in the United States are disproportionately affected. So here you can see the number of deaths reported on this illustration related to COVID for different areas in the United States. And the blue dots are the percent of deaths that are Black, and the green dots represent the percent of that particular population that are African American. And so clearly you can see that the blue dots represent the fact that there's, for every proportion of people that died, the high significant overrepresentation of African Americans in many cities across the United States. In fact, the Center for Disease Control has shown that although African Americans represent 13% of the US population, they correspond to about more than 1/3 of the cases of deaths related to COVID. And that certainly doesn't only affect African Americans, but also Latinos and other minority groups living in this country. So here you can see data from New York to around mid-April, which is deaths per 100,000 population. So on the left side, you can see those that were non-hospitalized for COVID. You see a much larger proportion of African Americans and Hispanic or Latinos. And those that were hospitalized but survived, also a significant larger proportion of Latinos and African Americans. And unfortunately, the same happens to those that have died on the right side of the screen. And the reality is that one of the things we've learned is, I mean, this epidemic has really shown us that staying at home is a privilege that many cannot afford. So there are a lot of social problems that have really brought the fact that many neighborhoods have been devastated, while other neighborhoods have really been untouched by this disease. We've had a very similar phenomenon happen here in our hospital. This is data from the University of Colorado Anschutz Medical Center. And you can see that only on the left side of the screen, only 20% of subjects are white that have been admitted, 150 patients, whereas Hispanics and Blacks nearly correspond to about 60% of those that have been admitted to the hospital, which is very interesting considering the fact that in this state, Blacks only correspond to 5% of the population. There's a huge overrepresentation of Hispanics and Blacks and who gets admitted to the hospital. One thing that's important to know, this is data from the Center for Disease Control in Georgia, is that once patients are admitted, whether they're Black or other races, they seem to do equally well. So here you're showing the percentage of people who received mechanical ventilation or who died. And essentially, Blacks have the same proportion of having these issues happen to them compared to other racial groups. But having said that, the amount of people that are getting sick and are coming to the hospital is much greater among Blacks, Latinos, and other minority groups. There is a lot of anxiety right now as to what's going to happen with states opening, and many economies around the world, for example, in Europe, in Spain, and in France, in Italy, they're starting to open their economy. So what's going to happen with COVID? So you see the national forecast from the Center for Disease Control shows the cumulative reported deaths over time. So beginning in April, at the beginning of the epidemic, you see this large increase in deaths. And what happens next? These are different models that predict what's going to happen in the next 3 to 4 weeks. It really depends on how much contact reduction we have. So shown here are 3 different scenarios from the University of Columbia, the SEER model. It shows if we only maintain a 20% reduction in contact, we'll continue to see a very large increase in the number of deaths. Whereas if we see a 40% reduction, we'll see less deaths. However, we clearly, based on these figures, we clearly need to do much better in order to really reduce the number of deaths. In fact, the Center for Disease Control says that many of the elements that were used during the strategies in the mitigation need to continue right now in order for us to reduce the impact of this disease moving forward. And why we need to do this is actually very, very important and very interesting. So what you're seeing here is the danger of relaxing the lockdown too soon. This is Denver, quote unquote, double humped curve with a pandemic flu or Spanish flu in 1918. So this is the number of deaths per 100,000 population. So they're starting to see the first cases in September in 1918. Then they implemented the non-pharmacological interventions such as social distancing and reducing gatherings. The cases continued to increase, and then they went down, and by November, the interventions were removed. And then what happened was a major peak compared to the first peak. And so I think many of us are very concerned that relaxing social distancing can lead to second waves of the epidemic. So I'm just going to briefly mention some of the areas of clinical uncertainty that we hope to discuss during this webinar that we and others have experienced working with some patients in the ICU. One of them is for sure the need for anticoagulation. There's a lot of good data coming from Italy and China that the prevalence or the incidence of thrombotic disease is much higher on these patients. So, for whom at one point should anticoagulation be happening, and should it be followed on D-dimers or other parameters? I think it's important to identify and treat different ARDS phenotypes accordingly. For example, we know there are differences in compliance and gas exchange according to different phenotypes. And so are these different spectrums of the same disease severity, and should mechanical ventilation be different according to different phenotypes? Also, we've seen that many severe patients can develop these rapid onset of inflammatory responses, translating these that we call cytokine storms. So we want to know whether this occurs in patients that are unable to clear viral loads, and what is the best treatment approach, anti-IL-6 or the anti-inflammatories? Is there a potential role for steroids? And lastly, I just want to mention a couple of things, particularly since there were several questions coming from the attendees regarding discharge. So I'll just show you some of the guidelines that we use in our hospital. So for people that have been hospitalized, we discontinue isolation of COVID positive patients. They have to have at least 10 days from admission and at least must be afebrile for 72 hours without the use of any antipyretic. However, if they're being discharged to a long-term facility or rehabilitation or another hospital, they need to have at least 2 negative COVID tests 24 hours apart. For those that are going home, we recommend to continue with home isolation for at least 10 days from admission to the hospital and have no fever for 72 hours. And this is largely based on some data that the CDC released today that shows that it is very unlikely for you to find replication-competent virus in the airways after 9 days from admission. Now, what happens to those that were not isolated in the hospital but were at home? So for those at home, we recommend that we're sick for at least 7 days from symptom onset, continue isolation, and 72 hours without antipyretics, without a fever, and clinical improvement. However, if patients remain symptomatic or febrile, this may need to be extended from 10 to 14 days. Patients that are immunocompromised can have viruses that could potentially replicate for longer periods of time, and so we recommend at least 14 days from onset and no fever for 72 hours, and again, clinically improving. And they have to have 2 negative COVID tests 24 hours apart. And briefly, I just want to thank all of you who are taking care of these patients, which are incredibly challenging. And I've been inspired by our nurses, by our respiratory techs, by other physicians here and across the world, but my classmates in Mexico and other places who have taken care of these sick patients, putting their health at risk. And I want to appreciate them. And thank you so much for inviting me.
Right. Thank you very much, Dr. Holgan, on this nice presentation. Our next speaker joining us today from Brazil, Professor Carlos Carvalho. He is the head of the pulmonary department at Sao Paulo University. Additionally, he is pulmonary department director at Heart Institute of Sao Paulo University Hospital, and ICU coordinator for COVID-19 at Sao Paulo University Hospital. He will be talking to us today about global perspectives on COVID-19 in Brazil. He is muted.
I forgot the, I released the macro now. Let's put, where is my presentation? Oh, okay. Is okay my screen?
Yes.
Yes, okay. I'd like to thank you, ATS and the ALAT, for the opportunity to present to share with you how we are managing this coronavirus pandemic here in Brazil. I have no conflicts to declare. Nowadays, I have more than 100,000 patients confirmed with COVID-19 in Brazil, and more than 7,000 deaths. Looking for the deaths all over the world, we can see only Brazil, Russia, and India, who start the pandemic later than other countries as China or Europe. We are still increasing the number of deaths nowadays. In Brazil, where we can observe the mortality rate about 7% in May, and the part of Brazil, the southeast part of the Brazil, is around 50% of the cases with COVID-19. And the deaths beside the southeast is important in north part of our country. In northeast part of our country, the number of deaths is still increasing. In São Paulo state, with the 44 million people, when 21 million people in the state, the metropolitan city of São Paulo, in this region, this is the epicenter of the coronavirus in Brazil. In February, this is the city, this local, where it started the COVID-19 in our country. The number of cases is still increasing in São Paulo state. And new cases per day is still a huge number, as well as the deaths per day. We have only in São Paulo metropolitan area, in São Paulo city, only 12.2% is not occupied in ICU beds. In the state of São Paulo, 1/3 are not occupied until now. There is a huge problem for us. We are preparing our state to share, to discuss this pandemic since the end of January. During February and March, we developed a strategy to fight the coronavirus. The first phase, with the patient is still at home, we developed a app to be used by the people at home, and the result of this app asked to the people to go to the hospital, and after the consultant in the hospital, the patient can go back to home or register in a system that regulates the beds in the hospital. Maybe the patient, depends on the severity of the case, go to the ward or go to the ICU. It depends on the situation. The patient go back to hospital and then discharged to go back home. The patient will be followed during 12 months, during 1 year, to go to rehabilitation or to see what happened with his lungs after the coronavirus infection. And the group of patients we died, we performed a minimally invasive autopsy to discuss how all organs will be compromised by the virus. This is our scenario in São Paulo. This is our complex Hospital das Clínicas. There are 7 different buildings. Our decision was to concentrate all the COVID-19 positive patients in this central institute, and the others institute has other patients without coronavirus. Here, this hospital has 900 beds, being 100 beds ICU adult beds. And then in the last 5 weeks, we doubled the number of ICU beds. Nowadays, 200 ICU beds for the COVID-19 positive patients. In the next 3 weeks, we will increase the number to 300 ICU beds for this population of COVID-19 positive. And then a lot of effort is doing by our hospital, our people, and the Secretary of Health of the State of São Paulo to do this. In our hospital, the admission since at the end of March increased progressively. 50% of our admissions, the patients go back home. 14% death of this population. In 30 to deal with the pandemic. We have a respiratory intensive care unit at our hospital, and then we develop a protocol to take care of these patients, to treat these patients, and this protocol using telemedicine, we are training the people, the nurses, the respiratory therapists, and the physicians in other hospitals outside Hospital das Clínicas. We present our protocol and train these people. After this, we started the tele-ICU to take care of the patients in other hospitals in São Paulo. This is a photo of the training. And this area, as I showed you, represent, we are here in Hospital das Clínicas, and this is the other hospitals in the metropolitan area. We are discussing every day the respiratory failure cases under mechanical ventilation, and one hospital in the coast area, covering about 270 ICU beds in São Paulo. This is the training. There are a portal. The people can using this portal, it can make the training in these areas, and then after the presentation, we can discuss all doubts about one of each presentation, and then after the part of the training, we have some projects, research projects in different areas. For example, in autopsy, the patient has a CT scan image and then go to the area of the Department of Pathology. Using an ultrasound, we can get samples of the lungs, liver, kidney, central nervous system, and so all different organs. And then we are discussing the pathology and the extension of this virus can damage our body. And we have one section per week to discuss in the case. Nowadays, we are performing about 15% of the death patients are submitted to this kind of autopsy. We have also training in mechanical ventilation in different situations of this pandemic, non-invasive and invasive mechanical ventilation. Marcelo Amaro will present our discussion protocol. Thank you very much. This is my email address.
So Dr. Carvalho, thank you so much. That was fantastic. So I'd like now to introduce our next speaker, who is Professor Carlos Luna. He is a professor of medicine and a consultant of pulmonary medicine orientation for the Hospital de Clínicas Faculty of the Medicine at the University of Buenos Aires. And personally, Carlos has been a very strong contributor to the development of guidelines and guidance for treating community-acquired pneumonia. So Carlos, it's all yours.
Thank you very much. My presentation will be about the antimicrobial therapy in patients with COVID-19 with lung infiltrates, and will be based in the guidelines that are about this topic. Not this topic in general, but pneumonias in general. No. Well, I have no conflicts of interest regarding this presentation. Well, first of all, I would like to show this slide. This is from the paper by Jane et al. Published about 5 years ago, and in which they made an epidemiologic study about the etiology of pneumonia. Here we can see that there were 2,500 patients, a huge study, and the commonest pathogens were 7 of them were viruses, and 5 of them were bacteria among the 12 commonest microorganisms. And we can see that there were 39% of isolation in the 2,500 patients, and the viral pathogens were more common than bacterial pathogens. But the most important thing is that there were 13% of those detected were co-detections. There were co-pathogens, virus and virus, or virus and bacteria. And this is something that happened we can see in some of the huge number of studies that were published, not exactly in relation with the etiology of COVID-19, but we have found that there were a lot of co-pathogens together with COVID-19 pathogen, the SARS-CoV-2, influenza, Staph aureus, Klebsiella, pneumococcus, Legionella, and so on. So, looking at this study that was made in Italy, a study about the etiology of pneumonia in Rome, and they decided to do this study the third week of between this third week of January up to the first week of February, just at the time that the pandemics began to increase in Italy, but there were very few cases at that time. And this was more or less at this time. And what they observed is, as you can see here, a lot of viruses, because this was at the same time of the influenza outbreak in Europe. But also there were different viruses. Here you can see just only 3 SARS-CoV-2, a lot of influenza, other viruses, but also some bacteria, including Mycoplasma, Legionella, Strep pneumonia. And we can see here in the right that there were a number of mixed infections. So mixed infection happen, and that is the topic why I would like to review the guidelines. Now the ATS is a guideline that were published during 2019. And one of the pico questions of this guideline was, adults with CAP who test positive for influenza, should therapy include antibacterial therapy? And the recommendation was yes, that standard antibacterial therapy has to be initiated in patients, in adults with radiographic evidences of CAP who test positive for influenza. And this is due to the reason that Staph aureus, Strep pneumonia, Haemophilus influenza, and group A Streptococcus usually complicate the evolution of influenza. Regarding the other indications related to patients that come with an infiltrate, they have a community-acquired pneumonia, and the therapy, the recommendations that should be applied to patients that are presented with an infiltrate and fever and so on. We do not have yet the diagnosis of COVID-19, but also could be a COVID-19, but for some time we have to think about another pathogen associated as a co-pathogen. So the common pathogens in the outpatients that have no risk factors are those staph pneumonia, mycoplasma, chlamydia, viruses, and in those healthy outpatients, others without comorbidities, the recommendation in the guideline is to use amoxicillin 3 times daily, and as alternatives, doxycycline and macrolides. Macrolides has been in the previous guidelines the #1 indication because it covers atypicals and also pneumococcus. But now there is a huge number of places in the world where there is a local resistance high for macrolides. In Buenos Aires, we have 27% of resistance, so we cannot use to all the cases macrolides because we have the risk to have a resistant pathogen to that. Pneumococcus will be a resistant pathogen. So if we want to cover atypicals, we should use in this case probably a combination. But this is not recommended by the guidelines as first election. Those patients that have comorbidities, now appears Haemophilus influenza as another pathogen, and this patient is more commonly may complicate if they are not treated with appropriate therapy. So the recommendation of the guideline is to treat them with amoxicillin clavulanate or cefuroxime plus a macrolide for treating typicals and atypicals microorganisms, including Haemophilus influenza. And the alternative is the use of monotherapy with respiratory fluoroquinolone. And those patients that have to be admitted, not in the ICU, and without risk factor for multi-resistance and microorganisms, the recommendation is to cover these pathogens, including the previously mentioned, but also Legionella, some enteric gram-negative bacilli, and MSSA. And the recommendation is to use a beta-lactam, maybe ampicillin, sulbactam, or cephalosporin, tertiary and you have to add a macrolide, a combination also, to cover those typical and atypical microorganisms. And the alternative is also, again, monotherapy with a fluoroquinolone. And well, there are another alternatives that they mentioned. And in those that have to go to the ICU because they have one major or the minor ATS is a criterion without risk factor for multi-resistant Staph aureus and Pseudomonas aeruginosa. Well, these are the pathogens more or less the same as the previous, but with a higher mortality in hospital mortality near 30% and 1-year mortality. So the coverage with 2 antibiotics active against pneumococcus is recommended, maybe beta-lactam plus macrolide or beta-lactam plus a fluoroquinolone, more or less with the same same kind of recommendations and quality of evidences. But when we suspect or we have evidence that may be the MRSA or Pseudomonas aeruginosa in a small number of these patients, the recommendation is also to cover this Staph aureus with vancomycin or linezolid, and Pseudomonas aeruginosa with the beta-lactam, anti-Pseudomonas beta-lactam, piperacillin tazobactam, or an anti-pseudomonal cephalosporin, like cefepime, ceftazidime, or carbapenem, like meropenem, imipenem. Patients with COVID-19 that are admitted to the hospital, especially to the ICU, are in risk to acquire a hospital-acquired pneumonia and in the ICU, a ventilator-associated pneumonia. And there are two guidelines that have been published 4 years ago and 3 years ago. The ATS guidelines, it's ATS, this version is, and the European guidelines together with ALAT that were published in the European Respiratory Journal. And more or less, the approach is the same in relation with that. The clinical diagnosis is very important to be done very quickly, and after that, it's recommended a lower respiratory tract sampling, maybe invasive, non-invasive, bronchoscopic, with qualitative or quantitative culture, but we need to have a sample. And then we begin with the antibiotics, considering the presence of multi-drug resistance pathogens. This is must to be related to the local microbiology for the different sites and different hospitals. And after 2 or 3 days, we will have the result of the cultures, and we will have the result of the clinical response of these patients, looking at the clinical data, and we will be able to see at that time if there is or not an improvement at 40, 48, or 72 hours. If there is an improvement, we can have positive cultures, and probably we will have the pathogen, and we will be able to do a de-escalation. This is something good to can de-escalate the therapy. Also, we can have negative cultures, and if the patient was not on the antibiotic at the time that the lower respiratory tract sample was obtained, in this case, we have to consider that probably there was not an infection, and you can stop the antimicrobial therapy. The worst situation is when there is an improvement. When the cultures are positive, maybe that you did not cover completely the pathogen. So this needs an escalation. It's undesirable to have to escalate, but it is what you have to do if you didn't cover the pathogen. And when the culture is negative, this is something maybe different microorganisms, complications, another kind of infection. No, this is the worst problem that we can have. Finally, there is a lot of patients, reading all the papers that have been published during the last 4 months, you can find a lot of patients that are members of this big area of immunocompromised hosts: HIV, chemotherapy, solid organ transplant, stem cell transplant, immunomodulators, drugs used for different objectives. Current situation is impacting not only our current practice, but also our personal lives. And in my opinion, this webinar can help us to, as with and our colleagues, to improve our behavior. But undoubtedly, the world changed a lot after the COVID-19 infection. Thank you.
Hello, everybody. Let's see if I can show my...
Sorry. Thank you, Professor Luna. I would like to welcome our other speaker from Brazil, Professor Marcelo Amato. Professor Amato is an associate professor at Sao Paulo University. He also served as the pulmonary department supervisor for the respiratory ICU at Heart Institute of Paulo University Hospital and scientific research coordinator for the Sao Paulo University Experimental Pulmonary Lab. He will be talking to us about the global perspective on COVID-19 in Brazil. Dr. Amato, Dr. Amato, go ahead.
Hello, good night to everybody, and thanks the ALAT for this invitation. So my topic is going to be to discuss some aspects of a patient that goes to the mechanical ventilation invasive one, and then I'm going to talk about the most severe ones. Everyone is a little bit aware that this is the main characteristics of such a new disease. So typically patients, they have severe hypoxemia, they have not big problems with PCO2, they have quite a good compliance, and I will return to this topic later because this has been very controversial. No one has doubt that it's a prolonged course, so we have to be prepared for 2 or 3 weeks of mechanical ventilation with lots of changes in the pathway, because these patients, they complicate a lot, especially because of this last item. They have lots of secondary infection, and this is very frequent. Something that everyone has been talking about is to pay attention to consolidations, because most of the patients, they have these ground glass opacities. They are, let's say, spread, patchy all over the lung, but predominantly in the dorsal parts of the lung and in the inferior part of the lung. But I call attention to these kind of consolidations that they suggest much more some gravity-related consolidation. So this is an indication that this patient has a high pleural pressure and high superimposed pressure, as you can see here. So lots of signals of atelectasis. Typically, there is a delay when the patient takes the CT and then when it comes to the ICU, but we have to pay attention because this is a big signal that this patient can be a little bit different. Coming from Italy, we have some data telling us that the compliance of these patients is not so bad. And if you see this histogram, most of the patients from this cohort in Italy, they have compliance, the median compliance is 50, and with a very high shunt fraction. And this is a very high number for patients with ARDS, because typically a patient with that amount of shunt, they typically have 30 mLs per centimeter of water of average compliance. So this is a little bit different, and this is why Luciano Gattinoni and some other Italian investigators, they have proposed that we have 2 types of patients. One patient that have very mild infiltrates and light lung, and another patient that has a high superimposed pressure with dorsal infiltrates, gravity-oriented, high densities in the CT, and these patients should be treated a little bit different. I agree with this idea that we have a big spectrum of patients, but I don't believe that we should treat them in a different way. And this is because in the last weeks, we have had lots of physiological studies, not only in our ICU, but also in other cohorts. And for instance, this is a cohort of patients, of 60 patients treated in Boston. We can see that for these patients, compliance was not that high. The average compliance was around the 30s. And these patients, they had, according to these data, a higher PEEP requirement. And in the Italian cohort, the suggestion was that when the patients, they have a good compliance, you don't need too much PEEP. They both need protective ventilation, but you should be more strict when compliance is low. We don't agree with this recommendation, and we have some data showing that, in fact, we should individualize and make some assessment of the patient at entry. So it has been also described that many patients during this disease, they have normal X-rays, relatively normal, like in this patient, except that the left diaphragm is not visible, and this is a signal that you should have some atelectasis or pleural effusion, most likely atelectasis, because these patients, they make lots of atelectasis in the inferior lobes. When you have severe hypoxemia and almost normal X-ray, many investigators have described the occurrence of local thrombi, and it's not only thromboembolism, but a local thrombosis due to hypercoagulability state that these patients, they have. So this is important because we should be actively searching for signals of thrombosis or thromboembolism. And I have seen quite a few cases in which massive thrombi was found in the main pulmonary artery. It has been also described cardiac failure, making the clinical scenario worse in the ICU, and a hyperinflammatory status, which requires some active measurements, active treatments also, because this can promote a lot of hypercoagulability. It can promote some big inflammation and organ failure. And there are some reports that some specific treatments can help us in this situation. But my major point in this short presentation is that above everything, we should treat these patients as we had a long-term general anesthesia. And it's going to be an anesthesia that is going to last for 3 weeks. Why I'm saying this? Because it has been shown recently that patients under anesthesia, they require protective ventilation as much as a patient with ARDS. The rate of complications is much lower, but they still need protective ventilation. They still need tidal volume control. They need control of plateau pressures and driving pressures, and they need some level of PEEP, which should be individualized. And this is exactly what we have seen. In our ICU, we have seen new patients with a little bit different from the past, because we had a higher incidence of obesity. And as we have shown recently in patients under anesthesia, if they have, especially when they have overweight, even using minimum PEEP of 4 or 5 centimeters of water and protective ventilation, these patients develop massive atelectasis during anesthesia. And this is just 3 hours of anesthesia. You can imagine what happens after 24 hours or 1 week of mechanical ventilation at low PEEP. And when we individualize the approach of PEEP to these patients, we reduced a lot the amount of atelectasis. And this has been our approach in our ICU. So we are doing a randomized trial in which we are trying to individualize the treatment and the PEEP level in these patients, because some patients, in opposition to what have been described in the literature, they need very high PEEP, even if the lung is not too heavy, but they need high PEEP because of anatomical factors, as some patients during anesthesia. In this cohort of patients during anesthesia or post-operative phase, we have here in the x-axis body mass index and optimum PEEP measured by electrical impedance tomography. So this is just the minimum PEEP in which you don't have decubitus atelectasis, and at the same time, you don't have too much overdistension in a normal lung, which could compromise the cardiac output. And using this right amount of PEEP, we could avoid the decubitus atelectasis, the atelectasis promoted by a patient laying down for many weeks. And at the same time, we could avoid overdistension. And as you can see in this graph, the PEEP requirement can be very high, some patients needing 16 centimeters or 17 centimeters of water of PEEP. And this is exactly what we have seen in COVID-19 patients. And so these patients are going to be under mechanical ventilation for many weeks, and we have to treat them individually and paying attention to the individual and specific patient physiology. Some patients, even having the same body mass index, they have very different PEEP requirements. And this is why we have been proposing that for these patients, we try a kind of standard approach with PEEP levels of 10 centimeters of water as a starting point, but as soon as possible, we individualize and try to find the sweet spot for every patient. Which are the benefits of finding this sweet spot is that we can reduce the driving pressures by as much as 6 centimeters of water, which promotes a much higher lung protection along the time that this patient is going to be under mechanical ventilation. And we're using this approach, and this is an average of 12 patients that we collected in our ICU, using this individualized approach where we can do one of both. If we have electrical impedance tomography, we use this technology to titrate PEEP. But if you don't, we just promote a gentle PEEP titration, and we have described this in some webinars available in the internet. And then we can promote a much larger reduction in driving pressures along the 2 or 3 weeks of mechanical ventilation, something like 5 to 8 centimeters of water reduction in driving pressure in these patients. And when we just follow the tables, we just get a neutral result. We have lots of data to show that this approach, we have not data specifically for this population, but we have data in patients under anesthesia in which if we can avoid these large driving pressures applied for a long time, we can reduce pulmonary complications. And this is something that we have been proposing. Obviously, this has to be tested in a randomized trial, and this is exactly what we are doing now. Okay, this is the main message that I would like to promote for this topic and this conference. I just wanted to show that these patients should be treated as a long-term general anesthesia, and all the principles of protective ventilation should be applied, and we should not treat these patients as something different, as a different type of ARDS. They are acute patients that they need protective ventilation. Thank you very much.
Okay, well, Dr. Amato, thank you so much for a fantastic presentation, and a huge thanks to all of the presenters. That was fantastic. So at this point, we now hand things over to Dr. Zabert, who's going to be leading the Q&A portion of this. We have quite a number of questions from the audience that I think we've been able to coalesce. And so with that, I'm going to hand this over to Dr. Zabert. Thank you.
Thank you. Thank you very much for this 4 fantastic presentations. The first question would be for Fernando, and the question was related with healthcare providers that had been infected with COVID. When is the time period that you consider appropriate to bring them back to work?
Hear me? There we go. Thanks. That's a very good question. We follow the same rules as to discontinuing isolation. So if someone is sick in the hospital and tests positive, they have to remain in isolation for at least 7 days from the onset of symptoms, and then they have to be 72 hours without fever, without the use of antipyretics, and without symptoms. That is if the test was positive. If the test was negative, then they have to be free of fever for about 24 hours before they return to work without the use of any antipyretics. But we test every healthcare worker that's symptomatic.
Thank you. Thank you, Fernando. The second question may be to Carlos Carvalho or Marcelo Brito, and it's a question from Brazil, asking about the extubation rate from those people who are on ventilator of COVID. Carlos, please unmute your mic. Carlos.
It's okay.
Microphone, Carlos.
It's okay?
Yes.
It's okay. Okay. These patients, they stay a long period at the ICU. And one moment is very difficult to manage. When we stop the controlled ventilation to put the patient in the assisted or spontaneous ventilation. This is a trick moment. And then he started the period of weaning. This weaning period sometimes is very long due to the patient needs lots of sedation. And this is very hard to manage this situation. Mainly during 2 weeks that normally this patient needs of mechanical ventilation. The extubation, you need, for the extubation, you need normal situation in the lungs. Maybe you needed to a less amount of heat. You need a good gas exchange. You need a important period of hemodynamics, and then you need the patient became in good condition of conscience. And sometimes it's difficult to get all this point, and then you need to control this patient for a long period.
Thank you, Carlos. We also have some other questions that we have received in advance, and I think there are 2 very interesting questions. Both of them are related with the patients that need ventilation, and one is related with non-invasive ventilation, and the second one is related with the option to go through tracheostomy in patients that are farther than 1 week or so. So there's 2 questions related with this issue. Maybe Fernando, Marcelo.
Okay.
Let's split it. Marcelo for non-invasive and Fernando for tracheostomy.
Okay, non-invasive ventilation has been a problem for these patients because of the fear of contamination. I think part of this is sounding, but part of this is not proven. And for instance, we have data showing that an oxygen catheter can be as bad as a non-invasive ventilation in terms of spreading. So I believe that any oxygen should be, any supplementary oxygen should be considered as a danger. And but we should not guide, let's say, the decision of putting this patient under invasive or non-invasive ventilation based on contamination, because I think everything we do with these patients is as dangerous. And I prefer to use the same approach that we use for an ARDS patient, with one caveat. First is that we know that for these patients, the amount of care we can provide is not so intense as a typical patient. So non-invasive ventilation represents a bigger challenge for these patients because of the problems when we have to enter the room. And for this reason, we should be more conservative when extubating the patient and putting him under non-invasive ventilation, because it's already a big problem for ARDS patients, and for these patients is much more. And this is why we are very conservative with our weaning criteria. And very rarely we indicate tracheostomy.
Thank you.
Okay, Fernando, do you?
You know, I don't think there's very strict guidelines as to when to have tracheostomy, and it probably varies a lot from center to center. I can tell you that in our own clinical experience here, surgeons were a bit reluctant to do it because they were concerned about aerosolizations, and I think we were postponing tracheostomies too late. I think the consensus is if a patient needs it after 21 days or so to do it as a standard of care. Most of them are done in negative pressure rooms. Sometimes we do them at the bedside, percutaneously, and with patients on full paralysis to avoid any coughing or anything that could produce excessive aerosols. But you know, I don't think that we've come to a consensus as to when do tracheostomies, other than as Dr. Amato says, just based on the standard of care.
Thank you, Fernando. Thank you, Marcelo. I have a question for Dr. Luna. In the scenario of COVID, what would you think the proper score that should be used as if it is a community acquired pneumonia? What would you suggest? Which score or severity score would you recommend? Or in case of no one, would you consider to use a biomarker as a severity score add to those? Your microphone, Carlos, your microphone. I can't hear you.
Oh, okay. You can use C-reactive protein, but C-reactive protein is also active if there is not another infection besides the presence of another pathogen different to COVID. Probably procalcitonin is good because procalcitonin does not go up when you have a COVID infection, exception with a very severe infection. Maybe this the marker. Regarding the scores, you can use, if you want, the COP 65. It's not a bad score because the COP 65 is speaking about severity. The COP 65 of 5 points is the same if you have a pneumonia, if you have a cerebral vascular accident, if you have another kind of peritonitis, you will have a high score, 65, and it is not. Yes, it works at this situation regarding to the scores.
Thank you, Carlos. I think we have one time for one more question, and the question is related with with asthma and those patients who are on biological treatment for asthma. What do you experience in terms of severity of the patients with asthma? And the other question would be, what do you do with those patients who are on biological treatment and asthma, but it may happen with other kind of biological treatment?
So it's okay if I take this one on? So I think most of us have been really surprised to the fact that asthma has been notably absent from the epidemic. And if you look at the symptom, you know, you don't hear a lot about wheezing. And there's two important publications that show both experimentally and clinically, the level of ACE2 receptors is lower on patients with asthma and patients with allergic asthma. That was just recently published in the American Journal of Respiratory and Critical Care last week. So, you know, and interestingly enough, the people who are using inhaled corticosteroids are lower level of ACE2. So what we can tell for sure is that people with asthma do not have worse COVID, are not more susceptible to it, and in fact may be protective either by their nature of their disease or by the use of medication. So it's quite interesting. You know, I'm not sure that we know the effect of biologicals at this point on COVID. My suspicion is that they're probably not a big player, but I really don't know any data.
Okay, is there any other opinion about that? Marcelo?
Just to remind you all that there is a recent paper published in JAMA that was paying attention to some patients receiving biological agents, especially for rheumatological diseases, and they don't have a higher incidence of problems. In fact, they look a little bit protected, but the data is not compelling on this, so we should not be worried about a patient taking a biological agent.
It's fascinating. We were really worried about, for example, our transplant patients, and transplant doctors, they've told me that the experience across centers is that they're not seeing a lot of severe COVID among them either. So
there also have been a very high concern about patients who are receiving ACE inhibitors, and we have some papers reviewing these issues. Can you comment on that?
You're talking about the New England Journal of Medicine study showed less odds of having severe disease, people that were taking ACE inhibitors or statins. And another recent paper on circulation, also from the Chinese group, I believe, with a propensity match analysis showing less odds of severe disease or death on people with ARB or ACE inhibitors. So I think the consensus is that they might be protective, but they certainly don't make the disease worse.
Okay. And one last question for Carlos Luna. What is about BCG and COVID, Carlos? The easy one. Unmute. Carlos?
Yes, regarding the BCG, there is interesting, has been suggested as a possible agent to prevent coronavirus disease. Several studies were underway to investigate this possibility, but even if they are to be effective, many questions will remain. Its main utility is in the prevention of tuberculosis, meningitis, or disseminated tuberculosis. It is also used as adjuvant in immunotherapy in patients with invasive bladder cancer. So there are several mechanisms through which BCG may produce a non-specific protection against respiratory infections, but there is a lot of things that we don't know yet. So I think that this is another possibility that we cannot say now if it is useful or not. We need a study again, as with different drugs that had been proposed.
Thank you, Carlos. Well, we are almost on time, and I want to thank ATS, ALAT, and SBPT for this fantastic webinar. And I want to transfer the mic to David in order to do the final remarks and comments.
Well, thank you so much. And before I forget, Carlos, I think BCG is going to have to be a dedicated topic. It's an amazing story, I think. So, but on behalf of the participants and the ATS International Health Committee, the Latin American Thoracic Association, and the Brazilian Thoracic Society, I wanted to thank all of our presenters for the perspectives, recommendations, and strategies in I think a fantastic conversation. A quick reminder, please complete the evaluation so that we can identify future topics besides BCG and approve the series. And I invite all of you to join us for future presentations of this webinar. And I wish you all health and safety during this epidemic or pandemic. And my thoughts and our thoughts are all with you. So with that, thank you so much. And I need to thank Nicole and Christina and the ATS staff for doing a phenomenal job. So thank you so much.
Thank you, everyone. Stay safe.
Thank you very much. Great work. Thank you, David. Thank you, Samya. And of course, all this stuff.
My bake's on the wall. I'll show you that later.
Thank you.
Thank you.